Yeah. So what sort of investigations are useful for diagnosing brain tumours, Catherine?
Yeah. So the gold standard is an MR brain scan with contrast, and that is the investigation which allows us to both diagnose the tumour but also plan treatment, make judgments about what type it is, what grade it is, and plan treatment. But that's obviously not the first test that everybody tends to get. A CT scan is often the first scan that people get, and that's obviously what general practitioners may be more likely to have access to. But it's really important to just talk a bit more about the use of CT scanning. So a CT scan will show something really gross. So if you have a big malignant brain tumour causing intracranial edema, causing mass effect, it will show on a CT scan. But you can't say anything more than that off the CT scan other than there's a tumour, needs an MR scan with contrast. But importantly, a clear CT scan or a CT scan that does not show an abnormality is not necessarily reassuring, particularly in younger people. So some of the low-grade gliomas are completely invisible on a CT, and just because someone has had a clear CT should not be reassuring if there are other symptoms of concern. It's an MR brain scan, which is the investigation that's needed. I would also say we talked briefly about opticians, and I can see somebody, I'm just sort of scanning through the questions, and without wishing to steal our thunder for later, somebody has asked about doing fundoscopy wearing PPE. Opticians are a super resource, because the opticians, we all know how difficult it is to do visual field tests and fundoscopy and so on in the clinic. And as the years go by, papilledema becomes something that we see less and less, and we may not feel confident about being able to pick it up. But the opticians are a wonderful resource. High street optician, visit to a high street optician, any kind of visual change, because a deficit on the visual fields is really hard neurology. There's pretty much nothing else that causes that type of homonymous hemianopia where somebody has loss of the visual field on one side because a tumour, say in the parietal lobe, is blocking the pathways as they go from the optic nerves round to the back of the brain to the occipital lobes. And so visual field testing and retinal examination done by a regular high street optician is a fantastic resource and a fantastic reassurance if it's normal, and a fantastically sensitive thing to do, because the optician will then either come straight back to the GP or refer them straight to A&E themselves or straight to ophthalmology.
That's really helpful. And then I suppose the other thing that I know actually in Greater Manchester we can't request CTs and MR brains, or certainly in Manchester I can't, for suspected tumours. What's the concern about incidental findings in these patients? Because it is something that worries me a bit.
A lot. Yeah, the rate of incidental findings on brain scans is really high. I think it might be up to 10%. There are all sorts of little oddities that are seen on brain scans, different types of cysts, vascular abnormalities, lots of things which are completely inconsequential. And it can be very difficult. And so the role of a brain scan to reassure people can actually be counterproductive, and so we ought not to be thinking about doing brain scans to reassure people, because actually it can just open a whole different can of worms. If somebody then becomes aware that they have something inconsequential like a pineal cyst or some sort of little arterial malformation, it is possible for people to become very hooked and very fixated on the idea that all of their symptoms are being caused by that abnormality, and for it to be difficult for them to accept reassurance that that abnormality, first of all, isn't responsible for their symptoms, and second of all, often doesn't need any other action. It doesn't need monitoring, it doesn't need anything else. And so caution, yes, because you unquestionably do get quite a lot of incidental findings on MR brain scans. So again, back to taking a clear history and using the MR scan to confirm suspicions, not to rule out trouble in people with headaches who are otherwise well.
Sure. Can I just add to that the headache that we worry about the most as neurologists in this population of patients, we're talking older patients, is actually giant cell arthritis. And that won't be picked up on an MRI. And that is the one that will make people cry. And if I get a referral about new onset headaches in a 65-year-old man, I don't really want to know what the scan shows. I want to know what his ESR is and what his CRP is. So that's really the key thing to bear in mind. And if his temporal arteries are tender, the patient needs urgent treatment. And that is far more common than a brain tumor presenting with a headache. So I would worry much more about inflammatory conditions than brain tumors in these patients. There's a couple of questions about cervical spondylosis and migraine in older patients. Should I go into those now? So the thing about cervical spondylosis.
No, Carrie, I was just going to say, particularly, I think that there's a couple that have asked quite clear how concerning new onset of migraine in an older patient is. I suppose we're very clearly taught now that new onset IBS in an older patient is of concern. Is new onset migraine in an older patient a burn?
It would be if it's genuinely a new onset condition. Okay, so we often refer these patients as new onset headaches, and when you ask them about it, well, they always used to get a couple of days of headaches around their periods, once a month or something like that. Oh yeah, that's when I used to go to bed for a day around my periods. Well, that's actually not new onset. But if it is genuinely new onset, then yes, that patient really does require a scan. So if there is absolutely no history of similar headaches, and that might be headaches that are milder and maybe not associated with quite so many additional symptoms. So they would just have a frontal throbbing headache, which makes them feel a bit sick, and they have to take paracetamol and go to bed for a few hours. That type of headache is often there in the history. But if it is genuinely a new onset headache and somebody who's never had anything like that before, then yes, they do require assessment, A, to confirm the diagnosis, and B, to have imaging. So those patients probably should be referred, but not necessarily on the 2-week wait pathway unless you have other things, such as progressive neurological deficits or papilledema or something like that. Because
questions that came up was something that we talked about, I think, when we did the module, is the fact that migraines can worsen quite considerably and that they change in severity over people's lifetimes. And I think that's one of the things that worries us. And I think our patient in the module has got worse migraines, so she's convinced it's something else.
Absolutely, yeah. So it still is a migraine. No matter how bad it gets, it's still a migraine. And the scan is not going to add anything to that patient's management. We sometimes end up doing a scan just to mollify the patient, just to reassure them and so on. But as Catherine said, it often ends up creating more problems. You end up with what we call incidental illness, and we call those people vomits, victims of medical imaging technology. And they have a whole lot of anxiety, which then requires more input from psychology and psychiatry and all the rest of it. And as I said, the most worrying headache in adult patients, especially older patients, which is giant cell arthritis, is not excluded by a scan anyway. So a scan is not the answer for a serious headache. It's a proper history followed by appropriate referral investigations.